Well, hello everyone, and welcome to today's Essential Substance Abuse Skills webinar series. Sorry about that. If you heard my little reminder, um, probably just telling me that I have a webinar. So thanks for joining us today, and we are going to be talking about treatment knowledge today, and our presenter is our wonderful friend and colleague, Bob Rarrett. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. We are one of 4 national focus centers serving the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification exams, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. Please check out our other upcoming webinars in this series, as well as our American Indian and Alaska Native Behavioral Health series, which takes place on the first Wednesday of each month. We always welcome suggestions of topics or speakers, so feel free to make suggestions either in the Q&A pod or by contacting me at the email address or phone number provided on this slide. Our center is a NADAC certified educational provider, and CEHs are available on request for a $15 fee. A request form is available for download in the files pod in the webinar screen, and we will also be sending this form out in a follow-up email to all who attended. Immediately following today's webinar, you will be redirected to our GIPRA evaluation. Actually, now that I say that, we won't be redirecting today. We've just had a few little hang-ups with some of our staff changes, and we don't have the survey ready to go right after the webinar today, but we will be sending the link to the survey in our follow-up email, so we would appreciate it if when you see that follow-up email, which should come to you either this afternoon or tomorrow, that you might take a few minutes to fill out that survey, because that is very helpful for us to plan our programs and to make improvements. You will be muted for the duration of this webinar, so if you have questions about the presentation or about the Adobe Connect system, please use the Q&A pod by typing them in the field at the bottom. We will address questions at appropriate points during the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. Today's speaker is Bob Rarrett, and Bob has worked in the field of addictions treatment for over 20 years, and he's currently serving as the Executive Director of the Minnesota Association of Resources for Recovery and Chemical Health, and has also been involved at our ATTC as an expert trainer for a number of years. He's been a great friend and colleague of us here at the ATTC, and is also a graduate of the University of Iowa MPH program. So we're really happy to have Bob and to continue having him be part of our work. So I want to pass things over to him, and I'll just get his pulled up here just a moment. All right, here we go. Thanks so much, Bob.
Thank you, Kate. Thanks for the nice introduction. You can hear me okay, I hope?
Yep. Yeah, sounds good, Bob.
Good, okay. Well, welcome, and thank you everyone for taking the time to spend an hour with us today. Kate referred to me as an expert in this area. I'm not sure that's true or not, but I find the longer I do this sort of work, the more I need to learn. It's a time in our field right now where healthcare is evolving rapidly, and addiction care as a part of healthcare is trying to find its way towards integration. And it's sometimes a crooked path, but the profession of addiction treatment, the work with co-occurring disorders that's going on right now, and the merging of mental health and addiction in terms of practice, and the efforts to to work more closely with primary care is changing the way addiction care is going to be provided and how systems are going to look going forward. So I understand this webinar is to help you prepare for licensing or certification exams, and I don't want to stray from that objective, but I hope you don't mind if along the way I sort of interject my thoughts around the evolving healthcare landscape and how addiction might fit into this new world of hopefully integrated healthcare moving forward. I would welcome if you have questions or if I say something that I don't make clear, if you can just submit a question or a note that says what your question is, or help me understand if I need to clarify a point that I was trying to make. The training objectives for this 1 hour that we're going to spend together are listed here, these 5 objectives. Some of the material is in here because, as far as we know anyway, this is the kind of thing that, these are the kinds of things that would be in an exam for professionals trying to get certified or licensed. So as these exams also evolve with the changes in healthcare, then we too will adapt or amend these webinars so that they fit more closely with the questions being asked on exams. But as of right now, these are the kinds of things in these objectives that we think would be helpful for you to know. So the first objective here is to have just a brief discussion around what evidence-based practices, best practices, promising practices are. I think these terms get used interchangeably oftentimes, and there really is a difference. There's a hierarchy of scientific rigor involved in determining whether something's an evidence-based practice, a best practice, or a promising practice. That's spelled out here. I don't need to read it to you, but just think of it in terms of evidence-based practices requiring the highest degree of scientific rigor in terms of determining whether or not that particular practice or intervention results in better outcomes. So when someone says evidence-based practice, if they're being accurate about it, it reflects an intervention or theory or some sort of practice that has undergone fairly substantial scientific rigor and has received support from like the, I don't know, I'm just throwing this out, but the American Medical Association or some well-known body that supports the research behind it. Best practices also are evidence-based, but they have a slightly lower degree of scientific rigor required to achieve that title. And then promising practices are things that show initially, anyway, show promise in terms of outcomes and how they might be effective in working with this population. Throughout the webinar, I use the American Society of Addiction Medicine as an example or as a standard in some cases for understanding addiction. The reason I do that, and ASAM is the acronym for this. If you're not familiar with ASAM, you should become familiar with it. Dr. Mealy, who's the chief editor for ASAM criteria, has developed a pretty comprehensive book or manual to understand ASAM criteria in depth, and the 3rd edition is the most recent edition of ASAM. But initially, ASAM was developed to help match the severity of symptoms in a variety of life areas, dimensions of health, to match those severity ratings with an appropriate level of care. So the idea is to try and be more objective, more scientific, if you will, about how we determine what level of care might be appropriate for somebody presenting with a certain set of life circumstances or symptoms. I think I mentioned the ASAM dimensions in the next slide, but when I refer to ASAM or reference it, it's because most states, if not all states, are either implementing ASAM as a standard of multidimensional assessment tool the standard for most agencies to follow. I know here in Minnesota, there's I would safely say that there's a lack of understanding around what ASAM criteria are and how they can be used. And the state and myself and others are involved in trying to figure out how we could better implement this multidimensional assessment tool and help to match levels of care with severity in a more scientific or objective way. There's still subjectivity to all of this, but that's why we're clinicians, so that we can make these determinations when there is subjectivity involved. ASAM defines, at least it describes addiction in this way, in this quote here: the inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems with one's behaviors and interpersonal relationships, and a dysfunctional emotional response. Now that's kind of a broad definition. The World Health, SAMHSA has a different definition. But the idea here is to look at addiction from a multidimensional view, so that we look at all aspects of health and environment in terms of influencing severity levels in these different dimensions. I don't want to get too deep into that, but I really think it's important for clinicians to understand ASAM, not familiar with it, to at least familiarize yourself enough with it that you can understand when it comes up why it's an important topic. I'm not a salesperson for ASAM books or anything. I just happen to have worked using these criteria for a number of years, and I think it's one way for us all to sort of get on the same page with respect to making recommendations for clients. That seems to be blank. Individual, family, community. There we go. Oh, I see. The goals for treating substance use and co-occurring disorders. Properly assess the client using multidimensional tools, like I just said. Whether it's ASAM or some other multidimensional tool, the important thing here is to realize that addiction care is a part of healthcare, not a standalone sort of service anymore. At least it's not going to be. So we need to be experts in this particular area of healthcare, but at the same time, understand how other areas of health, how environments, and how social interactions contribute to the challenges that our clients present with. So we have to look at the whole person, hear that a lot, I'm sure, and look at the whole person's health and situation, the context of their health problem. And in the case of cultures, I think it's critical, different cultures, it's critical to understand how that person from that culture, or how that culture in general, perceives illness and wellness. That is, how do they define, in this case, addiction? What does that mean to them in their culture? That's important because it helps us understand, first of all, how they view the condition, and then also allows us to ask, or to work with them and ask questions along the lines of what kinds of solutions, based on your understanding or perception of the illness, what solutions do you think would be helpful to resolve some of these issues? So cultural perspectives are critical in terms of understanding how that person views their illness, and also how they view wellness and what it means to be well. I hope that makes sense. Like I said, if I say something that you're scratching your head over, just ask a question or ask me to clarify. Integrated and evidence-based approaches. Longitudinal care is a movement away from episode-based care or acute care treatments. Many of you, or some of you anyway, may have grown up in the environment where 30-day treatment stays were sort of the standard. The idea behind that is not based in science. That is, there's nothing I've come across that said 30 days in treatment equals better outcomes. I think that was or managed care organizations determined that this was how much treatment they were going to pay for. Longitudinal care looks at the illness over the lifespan, or the lifespan of the illness, I should say, So you treat the illness for a duration that treatment's required for. You don't stop it after X amount of sessions or X amount of days. Care can, like for any chronic illness, care can be continued for years. It depends on the severity, the person, the complications involved. But longitudinal care looks at treating the illness from a disease model perspective. So you're treating the illness for the duration of the illness at the appropriate dosage of care, the appropriate level of care. And you have to coordinate what you're doing with other areas of healthcare, like primary healthcare, mental health care, whatever else might be, whoever else might be involved in that person's care, and have that coordinated in a fashion similar to a patient-centered medical home or a behavioral health home model, where that person's care has a central treatment team that meets to discuss their goals, their progress, work with the client on achieving whatever states of wellness they are hoping to achieve. And to provide the optimum opportunity for health behavior change through the Therapeutic Alliance. The longer I do this work, the more critical I think it is to develop a human relationship with clients. That is, as an example, I used to manage a large withdrawal management detox center in the Twin Cities. And what I found to be most effective in working with this population, especially when they're in crisis like that, is to develop some sort of therapeutic alliance with the person. An example would be when people came into our withdrawal management center, the first inclination of staff was to start talking to them about alcoholism and addiction and opioid dependence, and just right away launch into these kinds of discussions with the person, which is exactly what most of the clients we served were expecting to hear, right? But I found that if we didn't talk about addiction right away, if we asked them general questions about discovering more about how they came to be in our facility, asking them questions about what they wanted following their treatment with us. What was it they wanted to achieve? What did they hope to achieve? What kinds of things stood in their way? But really focusing more on the strength side of things and saying, boy, you've survived so many things in your life, and yes, you're here with us today, but just the fact that you're here indicates that you've got resiliency, a certain set of skills that have allowed you to survive and function even with all of these barriers. To take the discussion in a direction maybe different than what the client is expecting you to take it in, and allow them the opportunity to explain themselves. It goes back again to this narrative of how they described their situation and their illness. When we did that, we began to develop a relationship between our staff and the clients that wasn't based solely on you have an addiction and we're here to treat it. That was the underlying foundation of why we were there. But the discussion and the rapport that took place between us and the clients had to take some time to develop. And once that happened, then people were more willing to listen to recommendations. They were more willing to talk to us about possible options that would help them to resolve their health problems. And I don't know if I said that real clearly, but the intention is to ask the person what constitutes the situation that brought you here today. And it didn't have to be a discussion focused exclusively on addiction, because usually there are many other factors at play that have led to a person ending up in a crisis situation. And it's important to listen to the narrative about how that happened. So building that therapeutic alliance is critical, I think, and it's probably one of the biggest indicators of successful outcomes and for continued engagement in the treatment process or the healthcare process with a person. So our goal is to improve the client's overall health and wellness. Yes, typically we work with clients who have addiction issues, but if we can improve other aspects of their life or help them to improve other aspects of their life, typically health issues are related. And again, people are definitely connected to their environments. So if there are other kinds of improvements in their life, in the different dimensions of their life, then typically you stand a better chance, I think, as a clinician of seeing progress towards relieving the addiction or leading to hopefully the goal of abstinence, where the person can maintain some stability over time without using the drug. And we have to measure outcomes. We have to show that what we're doing has some sort of meaningful impact. Again, going way back to when I was starting out as a counselor, there were very few outcomes measured, and the ones that were being measured, I didn't think were all that helpful sometimes. Abstinence by itself is not a great measure of health um, in a longitudinal setting. Yes, you want people to remain abstinent. Yes, you want to help them reduce or stop their substance use, but you have to look at their entire picture again, the whole person perspective, and say, is their health improving over time overall? Those health measures are being examined pretty closely by states and by the SAMHSA, the federal government, to find health measures that are meaningful and really indicate and reflect, is this person improving over time overall? Certainly their addiction plays an important role in that, and it requires some focus, but health measures are moving more broadly to the whole person perspective. And to provide clients with informed consent, which means we have to make clients aware of the options available to them. Even if our treatment programs or our organizations don't offer a particular option, we still have to make the clients aware of what those options might be. An example would be opioid treatment. If, say, I worked in a treatment center that offered opioid treatment, but was abstinence-based. In other words, we didn't accept clients or treat clients with medication-assisted therapy. We only provided talk therapy or group therapy. If that were the case, I would have to make the client aware of other options in the community that were available to them, say methadone clinics or other kinds of opioid treatment options that maybe we didn't offer but were available to them. So the client can make an informed consent that, yes, I'll come to your treatment program, understanding that there are these other options out there. I'm just not going to take advantage of them. That's the essence of informed consent. So we just have to make sure we inform the clients that here's what we do, and here's some things that people do differently in other areas of the community. There we go. So what I tried to do is summarize what all this means. I see it as that we have a responsibility to improve service delivery and monitor client outcomes. We have a responsibility as professionals to constantly upgrade our skills, to constantly stay tuned in to what the current science behind addiction is, how it works, and what some of the best treatment, either promising best or evidence-based practices are in our profession. We can't stay rooted in theories that might be 40 or 50 years old, even if they're still effective in some ways. We can't stay stuck in the past. This is an area where science is evolving rapidly and where theories are evolving rapidly as to how to treat people with complicated behavioral health conditions. The term treatment even connotes a certain image in people's minds. If you say so-and-so went to substance abuse treatment, if you said that to someone in the general public, their first image is probably going to be of what they think of as treatment, some 30-day treatment stay locked in a facility with primarily AA as the foundation for the treatment approach. Now that may be the case in some instances, but the way that treatment is evolving now, treatment refers more to treating conditions, coexisting conditions, as well as specialty areas for a particular health issue. So when we talk about treatment, we're really any sort of medical care or behavioral health care is really treatment, right? I would even go as far as to say, I might be going out on a limb here, but peer support or peer support specialists are a form of treatment. They're helping the client move through maybe stages of change. They're helping the client to connect with other resources. To me, that's treating the condition. And I think we have to be a bit humble if we're licensed professionals or we've gone through master's programs to be clinicians. We have to be a little bit humble and be willing to give up some of our territory there and say, yes, we are specialists in this area and we are the professional clinicians, but there are other things that constitute treatment, and be open to those things. And peer support is one of them. There are other examples. Even self-help groups can be a form of treatment if you think about it, because they do help people to process and think through behavior change. So it's just that's my take on it. Anyway. You can disagree and you may be right, but that's how I view the evolution of defining treatment. Leave it at that, I guess. Again, we have to stay, as professionals, we have to stay informed about what best practices and evidence-based practices are out there. Stay current. Whatever means you have of doing that, whether it's through SAMHSA, through school, through National Council for Behavioral Health, but to stay in touch with the current science and research and best practices. Oftentimes there's a gap between research and practice. The researchers say, do things this way. The practitioners say, we can't afford to. We don't have the personnel to. We don't have the ability to. So sometimes it's finding that common ground between research and practice and saying, let's have a hybrid here, but let's also make sure that it still has some sort of measurement attached to it, some outcome measure attached to it, so we can tell whether or not it's working. And those, like myself and some of you, I'm sure, in leadership positions have a responsibility to mentor the next generation of leaders. I take that very seriously, and as people like myself begin to age out of the workforce, there's a vacuum forming right now where we need to start paying attention to talented people and clinicians who want to be leaders and help them become those leaders. Because I think if we don't do that, we're doing a disservice to our clients, and we're doing a disservice to those professionals that want to move in that direction. So the therapeutic relationship is what I refer to, I think, as a therapeutic alliance. These are basic things that you probably already understand: building rapport with clients, finding common and shared goals, building that trust and safety. I think it goes beyond that. Even as clinicians, you have a set of skills around empathy and around reflective listening and around motivational interviewing training, maybe, that help you, I think, as professionals, help you establish rapport, establish a connection with clients that maybe that probably people without any specific training would have difficulty doing, especially with this population of people with addiction, co-occurring disorders. They're often not the most, how should I say, they're not the easiest to get to know sometimes, and they're also not the most eager to jump into discussions about how to get well. So we have to find ways in which we can build those relationships to establish that trust and rapport and with the client, move forward, and hopefully a direction that leads to better health. Our ethical responsibilities are really around, in my mind anyway, around the boundaries that we need to establish when doing this. We don't want to cross any boundaries by inviting someone over to our house for dinner something of that nature. Obviously, we have to maintain those professional boundaries, but I don't think the two things are mutually exclusive. I think you can have a genuine, empathetic discussion with a client without crossing boundaries into um, something as substantial as inviting that person into your personal life. Power distribution is something to be aware of as a clinician, obviously, where you have power over that client, whether you feel like you do or not, or whether you try and present yourself as being on an equal playing field. There is still a power differential. You're the person oftentimes that controls whether or not that client goes to successfully completes a probation requirement, or whether they successfully complete a program requirement. So you do hold power over the client, and they view you as being on different a different level in terms of decision making and having control in their lives. So you have to be aware of that. I don't know that there's I mean that's going to exist regardless of how skilled you are. But I think you can diminish that sort of power differential by again establishing rapport and building that trust and those sorts of things. So you want to have some status as a professional that's good at what you do, and establishing with the client that yes, I can help you with some of these things. So you want to have the like a doctor would, you would want to have that ability to say, I think after getting to know them, I think this might be in your best interest, and having them value that opinion. And these are methods kind of building these relationships, but positive reinforcement and encouragement and still hope. Hope is a big thing. If you have someone you're working with who's devastated by their situation, obviously they're going to have a hard time seeing the top of the mountain. So anything you can do to establish some hope, some self-efficacy, yes, you can achieve these things. Maybe break those down into bite-sized achievable goals so the person can see that, yes, I'm making progress here, and build that self efficacy. Support, genuine empathy is critical. Uh, goals, the treatment goals, again, I'm not probably telling you anything you don't already know, but the treatment goals need to be, you need to have some say in establishing them. But at the same time, the client has to buy into these goals, or there's no point in trying to move in that direction. Um, it kind of goes back to what I said. Once you establish that relationship, you can begin to suggest things, or even not forcibly, but assertively say, you know, John Smith, I really think this is something you need to look at um, as a goal for care, because I'm concerned if you don't move in this direction that you may be putting your health in jeopardy. However you would phrase that, but the idea is to use your influence through that power differential to try and work with the client in moving in a direction that you think as a clinician is going to be beneficial to them. But they have to have the buy-in to it, or they won't obviously work too hard to achieve that goal. And just through your interactions with the client, through your interactions in general, how you handle situations, how you respond to criticism, things of that nature. If you can model that kind of adaptive interpersonal functioning, if you can show the client how to respond in certain situations through your own actions, that goes a long way. And people pay close attention to you, excuse me, when you're counseling them, whether you're whether you think they are or not, and they pay attention to the little idiosyncrasies that make us all up. Again, reflective listening is a good way to help clients feel as though they're being heard. Hopefully, they are being heard. Um, Reflective listening can be, if you are familiar with motivational interviewing, there are more advanced levels of reflective listening. One is you can just repeat back what the client said, and that can be effective. I mean, that tells them that you at least heard what they said. But there are more advanced ways to do that, where you paraphrase what they've said, or you make conclusions about what they said and reflect that back to them, that sort of thing, to see if you're understanding them correctly. It's just one way of letting the client know that they're heard. Genuine empathy helps people to feel respected and accepted. Non-judgmental kinds of statements, lots of open-ended questions, allows people an opportunity to express themselves without feeling judged or like you're going to disagree with them. Concern, let's see, working with people, not telling them what to do. Again, I'm dating myself, but when I began as a counselor, we developed the goals for the client, more or less told them, here's your goals for treatment. Good luck achieving them, I'm glad we've come away since then. Therapist has to show optimism that yes, you can achieve these things. Again, building self-efficacy for the client, or helping the client to build self-efficacy skills, and let them know that hope and change is possible. You have to reinforce that, obviously, throughout the course of treatment. This is just a brief overview of ASAM that I mentioned earlier. Some bullet points that sort of summarize what ASAM is intended to do. Again, it fits with that longitudinal model of care. It's not a prescribed length of stay that people are boxed into. There's a multidisciplinary approach, so you want to include, if you can, include other professionals that might be involved in the client's care, mental health professionals, primary care, docs, nurses, whomever might be involved, and peer specialists, I would add to that. Provide informed consent, all of these things that we've already kind of talked about. And clarify medical necessity. ASAM attempts anyway to clarify what the medical necessity for this particular level of care is. They spell that out clearly in withdrawal management. There's I think 5. I could be wrong on that, I'm sorry, but I think there's 5 levels of care within withdrawal management, from the ambulatory through medically managed, the hospital level of care. So within that continuum of severity, there's a medical necessity attached to each level of care. Now, just a quick caveat to that, parity law is in effect. It's a law that health plans and healthcare funders need to pay for behavioral health services like addiction and mental health at an equitable rate, comparable rate to other kinds of medical services. But that law is not being enforced anywhere really at the moment. There's an effort to do that. But the idea that when I ran, again, with that detox center that I ran, I would get letters from insurance companies that said, we're rejecting your claim because the service you're providing is not a medically necessary service, even though the person came in severe withdrawal, had life-threatening kinds of situations. So ASAM is a way to help quantify this set of symptoms may be medically necessary for the client. And it gives us some justification for how to argue that point, which we shouldn't have to argue in the first place. These are the dimensions of ASAM, real quick. I think they're self-explanatory. The 3rd edition of ASAM looks a little more broadly at co-occurring disorders, withdrawal management, and environment as a key factor. I think you can all get copies of these slides at some point, so if you want to reference them later, it might be helpful. This is sort of reiterating what I've already said, so I'm not going to spend a lot of time on it, but it summarizes a little bit of everything I've just talked about. The important thing about selecting a therapeutic approach, I'll go over a few here in a second, is to match the therapeutic approach with the client's needs. And also, I want to reiterate that culture plays an important part in determining what therapeutic approach to use. Um, I worked in Hawaii for about 3.5 years, and I had never lived there before. So when I went there, I was immersed in Hawaiian culture, and it was really a steep learning curve for me to see how culture influenced the way Native Hawaiian people viewed health and wellness. And the environment there is critical to health and wellness. That is, their connection with the land, with the ocean, um, was an essential part of becoming well, connecting with those aspects of the environment. And there were um, spiritual and other kinds of ceremonial activities that played. This holds true, I believe, with Native American communities as well. There are these kinds of activities are critical to um, wellness and to understanding illness better. So cultural implications, if you look at, again, the illness narrative and you look at how different cultures view health and wellness and illness, it's going to help you decide what kind of therapeutic approach to take. Motivational interviewing is, in my mind anyway, a fairly um, good approach to use with most people because of the, I'll get into it more. I guess I won't launch into MI right now, but it's a non-threatening, engaging way to connect with people. I think even people of other cultures, and I'm saying that in a very general sense. Now, I want to be mindful of what might be covered on the exam that you may be taking for certification or licensure. So, as far as I know, these behavioral theories are still prominent in those exams. So, we'll talk briefly about behavioral theory from Skinner, cognitive behavioral therapy, contingency management. It's now called incentivizing more often. SBIRT, RBT, or REBT, motivational interviewing, stages of change, and medication assisted therapy. This is meant to be a broad overview, so I'm not going to be able to get into a lot of depth on these, but I at least want to present the basic constructs of each of these theories. So for behavior theory, these 4 bullet points are what I pulled from behavior theory to sort of give you a sense of what that consists of. I don't want to read you the slides, but I want you to get the basic differences between the theories, what helps to differentiate them. And again, you can read this. So conditioning is a part of behavior theory. There's classical conditioning and operant conditioning. So under classical conditioning, it basically says craving can be a conditioned response triggered by stimuli. It could be in the environment or whatever the visually or auditory kinds of stimuli that the client may or may not be conscious of. There was a study done, this might be interesting to you, and I hope I'm not boring you to death, but there was a study done in the Netherlands where they took several people with active addiction. They placed them in front of computer screens that appeared blank to the subjects, the people that were in the experiment. And they put, I don't know, whatever kind of brain things, they put electrodes or something on their heads so they could monitor activity. And these screens that the people were looking at appeared blank, but actually the researchers were flashing images across the screen at 1/1000th of a second. And the images consisted of neutral images like puppies and houses and things. And every now and then they would throw in some drug paraphernalia. They found that the person's brain registered the slides that showed drug paraphernalia or whiskey or whatever it was, that their brains responded to that through elevated activity in the reward center of the brain. So even though the person couldn't visually see the slide, their brain responded to it through a heightened activity in that part of the brain, which triggers craving. So it's an interesting study because it shows us that even if someone isn't aware of something in their environment or something that triggers that craving to use a drug, that it can be present and it can cause that sort of effect. So it helps us, the purpose of that, I guess, is it helps us understand that not everything that triggers craving is a visual kind of trigger. It can actually be seen by the brain when it's not seen by the eyes. It's a fascinating study. Operant conditioning is the nature of the consequences will impact whether the behavior occurs again. So negative reinforcement, positive reinforcement. Contingency management is in incentivizing or offering rewards for positive behavior. It sort of fits with the last theory, in that you can offer, say, a reward for just throwing this out there, but like if you have a series of negative drug, or if you attended all your groups, you might receive a gift card or something, but some sort of reward was at the end of the positive behavior. There's actually some evidence to show that this is somewhat effective in promoting healthier behaviors. It does go into the detail of what kind of reward and what kind of premise you set up to receive the reward. So there has to be some planning involved. Again, some measuring to see if it's effective. But there's some promising results from doing this sort of thing. CBT, or cognitive behavioral therapy, is a commonly used practice and theory, and it combines behavior theory and cognitive therapy. It's a bit it's more complex than I think we often make it out to be, but it's helping people to think differently and better understand their emotions when it comes to their reaction to certain events, or how to manage their emotions or understand their emotions better. And it's not probably doing this theory any justice, but cognitive behavior theory is essentially trying to help people change the way they think about a thing and the way they feel about a thing, or look at other ways to think about a thing and feel about it. CBT is often used for relapse prevention kinds of activities or groups to help people look more closely at high-risk situations and how they could change their behavior in that moment, or how they think about putting themselves in high-risk situations, ways in which they can cope with those situations if they do find themselves in it. Again, building self-efficacy in an effort to, if you avoid a particular situation or you can get through it without using, how does that build upon your belief? And also to help people examine more closely their expectancies when it comes to responding to craving and using a drug again. Their expectancies for the reward versus the potential negative outcomes that could come from that. Finding lifestyle balance in general. The difficulty with doing cognitive work early in someone's recovery is that the brain, the way it's functioning for many people with more severe addictions, the frontal lobe, or the part of the brain responsible for executive functioning skills like logic and reasoning, can often be greatly impaired. And that person, even though they might talk and act normally, their brain is still impacted by the addiction to the extent that they're unable really to reason well and follow through with plans. So it's with a bit of caution that I say doing too much cognitive work early in someone's recovery can have unrealistic kinds of expectations for the clinician, because that person their brain may not be working properly yet, to the point where they can follow through with these plans that you've discussed with them, and their ability to reason oftentimes is impaired. So at the same time, craving is still very strong in the reward center of the brain. So you have this dynamic where craving is strong and the ability to reason and think logically is impaired. So you can see how relapse can occur even when someone's not consciously aware of that. REBT I put into a nutshell here, and I used an example, kind of a flow here of how this might be understood. Something happens to the client has an quote unquote irrational belief about the situation. The client has emotional reaction to the belief, and then the therapist helps the client recognize errors in thinking that led to the irrational belief. So I was only arrested for drunk driving because that cop has it in for me. Has it out for me. So helping the client work. Yes.
Oh, if I can just interrupt a minute. Elizabeth had a question. Did you about the study that took place in the Netherlands you referenced? Do you know the name of that, or a way we can find what that one was specifically?
I have to search for it. I had it in a presentation that a doctor with an addiction specialty had it in one of his slides, and he reviewed that study in some depth. But I have to find it, and I only reference it now for the message that it sent. But I need to find it, and I'll try and get that to you, Kate, when I do.
Great, thanks. Yeah, I'll make sure to pass that on.
I'm sorry I don't have it handy. I kind of just threw that in there. So.
Oh, great. We'll make sure we pass that on. Thanks so much.
Sure. So hopefully these bullet points help you to recognize when REBT might be the theory that is being referenced or alluded to in the question on an exam, or just to help you understand this is how I might think about this particular theory versus behavior theory. So the stages of change model, I'm sure most of you are familiar with. These are the 6 stages of change. Prochaska and DiClemente manualized a treatment approach for addiction treatment. This was based on work they had done around smoking cessation or tobacco cessation. And they adapted that theory to primarily alcohol use, but to addiction. And the stages of change are a way in which to conceptualize where a person is at in terms of their readiness to make changes in their life. Many of the clients that we might deal with are in their early stages of change, pre-contemplative, where they're not really considering, they don't recognize a problem to begin with. Contemplation, where they might recognize a problem but aren't quite there yet in terms of wanting to do something about it. Preparation is when a person's made a decision to do something about their health condition, and they maybe contact someone or are preparing to contact someone to make an appointment or have a consultation. Action is when the person actually follows through with that, makes an appointment, goes in to see a therapist, or follows through with a consult. Maintenance would be when a person has made certain changes in their lives, behavior changes typically, that they maintain those changes with ongoing support. And then relapse and recycle can be when, I don't really like the term relapse so well. I don't think we use the term relapse if somebody doesn't follow their diabetic medication regimen. We don't say they relapsed on diabetes, but we do use that term in addiction. And it refers to when someone goes back to using the substance, they might revert back to an earlier stage of change as a result of that. So these stages of change are meant to be fluid. People can move around within them, and it's up to the clinician to assess primarily where that person is at in terms of their readiness to change in order to use the appropriate theory or intervention that might match that readiness to change. I hope that makes sense. So you're trying to match the person's readiness to change to an appropriate clinical intervention. If you started, say, with somebody who was pre-contemplative and you started talking to them about going to AA and coming to aftercare groups, that person, or telling them that they have an addiction and they have to do something about it, you're going to be on completely opposite pages with them, and they're not likely to recognize that therapeutic alliance. Um, Rather, they're going to say, I don't have this problem. Why are you telling me to do these things? And then you set up a dynamic where there's confrontation, which is not what you want. This is a little more about motivational interviewing. It's a heavy slide, but it gives you some background. I'm going to kind of skip over it for interest of time here. But I will say motivational interviewing really focuses on understanding and recognizing a client's resistance to a particular pathway or line of discussion, and recognizing that resistance or that unwillingness to go down that road, backing up, and what they call rolling with resistance, but moving in another direction that might be more likely to result in some cooperative discussions with the client. So you're not having a confrontation with them in motivational interviewing. You're trying to recognize where they're resistant to a particular line of thought and moving in a different direction where they might have more I don't want to say buy-in to what you're asking or trying to tell them. There's much more to it than that, but I mean that's one of the key aspects of motivational interviewing. Collaboration. The client has a sense of autonomy. Again, genuine empathy. I'm trying to reflect back in a way to the client that helps them understand that at least you are trying to grasp what it is they're feeling or going through. Develop discrepancy. That has to do with if the client says something that's totally contradictory to what their situation is, that you try and gently develop some discrepancy and say, on the one hand, you said, your alcohol's not causing you any problems. On the other hand, you're getting a divorce and lost your job as a result of alcohol use. So I'm trying to understand how those two things fit together. Now, it wouldn't be that obvious probably, but it's that kind of discrepancy that you want to focus in on and ask for clarification from the client on. Roll with resistance, and again, support self-efficacy, which I think is a critical aspect of what we do. Many clinicians think they use MI. Many clinicians think that and don't use MI. It's very hard. This is if this is being explained in a few minutes, it's easy to say, well, I do all of these things. I'm very client-centered, and that may be true, but there are specific constructs in motivational interviewing as to how to present questions or how to work with the client to move in a particular direction towards one stage to advance them in the stages of change. And there's a lot of extensive training. If you've gone through it, you know this. At least a couple of days of fairly intensive training for clinicians, and there really should be ongoing supervision through taped sessions or mock interviews where you can monitor whether or not this clinician is using motivational interviewing as it's intended. It's easy to slip into old ways of thinking as a clinician and start to challenge clients on particular things, especially given the history of our field where it was much more confrontational historically than it tends to be now. So if you want to use this model, you can't, you can get the spirit of it from a presentation like this maybe, but you can't understand the clinical constructs that you need to use in order to make it effective. So I would just say if you have the opportunity to do more training around motivational interviewing, that ongoing sorts of training, I think it would be helpful as a clinician. SBIRT, and I know I'm running a little low on time here, but SBIRT, it's actually reimbursable now through Medicaid, but the reimbursement rates are so low that doctors typically don't do it. But it can be done through probably depends on your state, but done through other qualified health professionals, addiction counselors, mental health professionals, or maybe a nurse practitioner or a nurse. Screening and brief intervention is an opportunity to use a screening tool to gauge whether or not somebody may be at risk for a particular disorder, provide a brief intervention and sort of and think of it in terms of building that therapeutic alliance. So early stages of building rapport with the client, not being confrontational with them, but saying, this, we conducted this screening and there's some things on here that concern me, and I'd like to talk to you about that a little bit. If it comes to a point of referral, there should be a clear referral source that you know who to call and they pick up the phone when you call them, so that in that moment when you're meeting with the person, you can call the referral source, get an appointment set up right away, and there's not this lag time where you give them a business card and say, hey, call this place next Tuesday and they'll get you in, because that won't happen probably. And then again, the treatment provider oftentimes is the referral source that you're using. There should be a warm handoff to either who you're referring them to or the treatment provider if they're the same entity, and have either a care coordinator or that person doing the brief intervention do a warm handoff, whether it's over the phone or in person somehow, to say, here's so-and-so, we were talking about this concern that we had, and we'd like to introduce them to you. So there's a human connection between maybe two different services. SBIRT is also, again, is a well-researched intervention. If it's done well, it can be very effective. Many people don't need to go through the whole long assessment process in order to engage in treatment. In fact, many people would be able to be recognized in a primary care setting using this tool and be helped that way rather than having to go to a specialty addiction clinic. These are just 3 theories I thought were worth mentioning. And they tend to encompass the whole person with respect to assessing and treating conditions. So the one I will point out is the social ecological model at the bottom. This looks at multiple influences on a person's health and how those multiple influences interact. It can be, the benefits to this is it's more comprehensive and helps you understand the context in which the person has the illness. The drawback is that it's very broad and very cumbersome. So if you're a clinician trying to address all of these sort of global concerns that affect the client, it can be very daunting. You might have to say, I can't be everything to everybody. The idea here is that you work again with other disciplines, other areas of healthcare to sort of bring them together in that person's environment, in their community, and help them find ways to adjust and make changes within their community to improve their health. I'm going to run low on time, I think, but this slide attempts to show just what do you call those models where the bubbles overlap? I can't think of the name of them. Anyway, it shows the intersection of the different areas of healthcare that are now being or attempting to be integrated. Substance abuse, primary care. Problem gambling is another one that's now listed in the DSM-5 as an addiction disorder. And of course, the mental health field. A Venn diagram, that's what I was trying to think of. So this is a Venn diagram that, well, sort of, to show the intersection of these different areas. The people that we serve are often moving around within this whole, these different bubbles. And oftentimes, they're the same population that present in different places for different kinds of problems. This is a quick definition of co-occurring disorders. Co-occurring disorders refers to, in this context, refers to someone with a mental health disorder and an addiction disorder. Some of the mental health disorders are listed here: major depression, bipolar disorder, schizophrenia, and PTSD. PTSD used to be included under anxiety disorders in the DSM-5. It's now its own separate a diagnostic disorder, or disorder with diagnostic criteria. This is a more complicated population, and it's really the growing population that we all need to think about. Because of the complexity of mental health issues and addiction issues, and often physical kinds of health problems, this population is very difficult to treat. I think one way to do that is to move, which our healthcare system is trying to do, is to move more towards a preventive, health-oriented system of care rather than treating people at the back end of their illness in acute settings. So if we can shift the healthcare industry towards the front end of disease, we have a better chance of managing the disease and seeing better outcomes than if we just wait until people become acutely sick and then trying to treat them. That just makes sense intuitively, but we have to shift the whole system's way of thinking towards the front end. Not to say we don't still have acute services, but that we want to treat the front end of disease more effectively. I'm not going to focus on these because the axes went away with the DSM-4 TR. ASAM we talked about enough, I think. Some characteristics of co-occurring disorders. Again, I'm going to kind of fly through these. I'm going to leave a little time for questions. But you can look at them real quick. I think they're pretty obvious sorts of things. I would think the estimates vary, but I would say roughly 80% of the people that I've worked with over the years have probably had co-occurring disorders, whether substance use was to me, it doesn't really matter which is primary. I mean, you have to treat both things, and you have to determine if one was induced, if the mental health disorder was substance induced or not. I mean, that's important. But the fact that people present with both conditions requires, I think, a coordinated and integrated approach to deal with both conditions simultaneously. That's just a locus of care. People who present with low severity of addiction, low severity of mental health, primarily seen in primary health care settings. People with high mental health are seen in mental health settings, etc. I'm going to breeze through this fairly quickly. There are some medication-assisted treatment options like buprenorphine, naltrexone, Vivitrol. These are medications that are often used. We'll start with naltrexone and Vivitrol, are drugs that are now commonly used, or more commonly used with alcohol use. They are not to be confused with antabuse. They don't make you sick if you drink while you're on them. What they do work for, and a lot of people anyway, is to reduce craving and to diminish the effects of alcohol if somebody does drink, so they don't get the euphoria that they would typically get, which in theory helps in, or it weakens that link between using and getting the euphoric effect. Antabuse is seldom used, at least in my circles anymore. It still is used though, and Camprol is sometimes used with alcohol to assist with recovery. For opiates and opioids, quickly, the difference between opiates are they're a drug derived from the opium poppy, like heroin, morphine, and codeine. Opioids are the broader term used to include synthetics, like Demerol or fentanyl, oxycodone, things like that. Again, I'm going to skip through this rather quickly, but I didn't mean to skim these, but I don't want to run out of time. Buprenorphine and methadone, there's a lot of debate within the treatment field around whether to use medications for the treatment of opioid disorders. The research is pretty clear that medication-assisted therapy has better outcomes than abstinence-based models. Now, I'm not taking a side on this. Well, I kind of am. I guess research is on the side of using medication-assisted therapy along with talk therapy, group therapy, and things like that to improve outcomes. I am somebody that pays attention to what the science tells us. It doesn't mean I'm a going to blindly say this is the best way to go, but the outcomes are pretty clear that using appropriately using methadone, monitoring those folks closely, and providing other kinds of talk therapy can be more beneficial than an abstinence-based program. The withdrawal symptoms get too uncomfortable for people oftentimes without something to relieve that withdrawal, and they will bolt out of a treatment center or a detox center before you have any opportunity to help them further. So I guess I do fall on the side of medication-assisted therapy as possibly the stronger option. I have some slides on buprenorphine. Hopefully, like I said, you can review the slides at a later date, so I don't want to shortchange you here, but I also don't want to run out of time. I think I have till 1:15. Is that right, Kate?
Yeah, you're exactly right.
Okay, so can I stop here? I'm almost done with buprenorphine, and I think that's the last thing. Can I stop here and just see if there are questions or if I can explain something better than maybe I did?
Wonderful. Yeah, thank you, Bob. We already have had one question come in on your thoughts on aftercare, which is kind of a broad question. So, and I know Elizabeth already let me know that she had to go, but I said that we would get to this question and she can hopefully check it out on the recording. So I don't know if you want to go at that a little bit, even though it's a fairly broad question, or
I think aftercare fits into this longitudinal concept. So when somebody has an illness, regardless of the illness, they're treated for that illness until the acuity diminishes, and then whatever lower levels of support they need, they continue to receive. So aftercare or continuing care should be just a natural component of any chronic illness. For addiction treatment, it may involve ongoing groups, it may involve self-help, it may involve visits to your primary care doc. It depends on what the person wants and needs to maintain those changes that they've made and to help them stay healthy. And it should just be a natural part of any long-term care design.
wonderful. Thanks so much, Bob. We've just had a couple other comments. No other questions at this time. So yeah, did you please continue to submit questions. Maybe take a couple more minutes for if there's other things that Bob wanted to cover yet, but other than that, we'll try to finish up shortly. So please submit your questions if you have them.
I mentioned that naloxone is gaining some popularity as a method of preventing overdose from opioids. First responders are often getting doses of this now to help with overdose situations, but that's something that I would think we'd want to pay attention to going forward. Smoking cessation, let me make one final comment, and then I'll be quiet if there's any other questions. But smoking cessation or tobacco cessation in treatment settings has been also an area of debate. There are treatment programs that say if we don't offer, allow people to smoke, that they'll leave our treatment programs or they won't come to us in the first place. My argument is if we're healthcare providers, if we provide a healthcare service, then we should not condone one particular drug like nicotine that we know to be harmful and that we know contributes to increased relapse rates. My position on this over the years has changed a little bit, but I'm more of a believer that if we're going to call ourselves healthcare professionals, then we shouldn't allow tobacco use in an addiction treatment setting. It doesn't make sense to me. It would be like saying, well, it's okay to have a beer or two while you recover from your opioid withdrawal because it makes you feel better. It's a drug, it's a very addictive drug, and we know that smoking and tobacco use is deadly. So to me, it's ethically something that we have to take a stand on at some point or another. And say tobacco use in a addiction treatment facility is contradictory to what we're trying to accomplish here. Okay, I think that's all I had to say. I hope some of this is helpful to people.
Wonderful. Thanks so much for that. That was yeah, like someone else commented, a very comprehensive overview. That's absolutely true, and so thank you for covering so much and giving us some really good examples to see how this information is put into practice. And yeah, I want to thank everyone for joining us today. And if you continue to have questions, if anything comes up as you think about what I will make sure that we respond to those questions too. And I'll just remind everyone too before we close out that we'll be sending a follow-up email which will include the handouts. As Bob mentioned, it'll be a PDF of the presentation that was shown today, and you'll also get a link to the recording so you can view this again at a later date or share it with others if you think it would be helpful. And we offer this series every year, so we have the recordings on our website of ones that have been done in the past, and then you'll also see the upcoming ones there too. So yeah, again, thanks so much for joining us, and thank you again, Bob. And with that, I think I will close out and hope everyone has a good day.